So surgical site infections occur not too infrequently after spine surgery. The incidence of infection is quite variable, ranging from 0.2 to 16%,
Oh,
although
yeah.
um, 0.2 to 16%. Um, although perhaps more recently, the data has kind of converged down to 1.5% to 1% for instrumented or non-instrumented procedures. Complications related to infection may lead to readmissions, delayed recovery, possible further interventions needed with antibiotics or return to the operating room. Ultimately, this adds a very unexpected burden to the healthcare system, as well as to the surgeon, and most importantly, to the patient. In terms of looking at the described risk factors, there's several data sources now contributing to identifying these risk factors. This is the National Healthcare Safety Network data. They identified a point system looking at ASA score, wound classification, and duration of procedure being greater than the 70th percentile. That ends up being greater than 2 hours and 46 minutes for a decompression and greater than 4 hours for spinal fusion. That's kind of all comers, so it's a little variable in terms of how many levels are done. So based on their point scoring system, you can see a increase in surgical site infection rate as you go up in points. And you can see this is true for other surgeries as well. Their specific list of risk factors they saw that were significant included high ASA score, diabetes, obesity, revision surgery, smoking, UTI, hypertension, transfusion, CSF leak, and higher blood loss, older age. Recently, surgical site infection research has looked at preoperative nutrition index as a modifiable risk factor. This study was from Japan and showed 4% overall infection rate, with the nutritional index being worse in those infected. That nutrition index is based off of serum albumin and lymphocyte count preoperatively. I think this is a focus of research now because, unlike a lot of the other risk factors, the proper nutritional status can be modified. So if they're on the wait list for surgery or they're scheduled out, there's some time to try to improve that nutritional status prior to surgery. Post-operative infection is also important because leads to inferior clinical outcomes. So this study looked at 30 patients who underwent fusion procedures that had acute infections within 3 months. This group of 30 was propensity score matched to a non-infected control group, and the ODI, SF36, and VAS scores were collected for outcomes. And at 2-year post-op, despite resolution of infection, the infected group had slightly lower scores overall, with the back pain score being significantly higher and fewer patients reaching the minimally clinically important difference for the ODI outcomes. So despite having control over the infection, still seems to portend lower long-term outcomes. This study also asked the same question, looking at 13 patients who had infection compared to propensity scored cohort 3-to-1 matched non-infected group. And at around 2-year follow-up, they showed no difference in clinical outcomes, but the questionnaire asking would you have had the same treatment results again was significantly different. Over half of the infected group felt unsatisfied with their outcome, compared to 15% in those who were not infected. So that's still pretty high, even with you know things going well. 15% of patients have some kind of decisional regret in this small cohort. This study compared surgical site infection rates between open and MIS techniques, which is also gaining more and more popularity. They had over 1,400 cases and reported a low infection rate of 1.5%. But they did reach clinical significance in comparing the decompression only group with the open decompression having 4% infection rate versus 0.4%. So just one center's data, but they suggested that the MIS sort of approach possibly does reduce infection, perhaps by less blood loss, shorter surgeries, and shorter hospitalizations. Notably, in this study, and minimum follow-up of 3 months for this acute infection period. They drains in the open cases and no drains for the MIS cases. In terms of the pathogenesis, the most common source of bacteria is transmitted endogenously through the skin flora at time of surgery. Common skin bacteria, usually it's gram-positive, coag-negative staph, or staph epi, or P-acnes. Half of all these surgical site infections are attributable to staph, and there's a significant percent of them that are methicillin resistant as well. So this is a series of 239 infections from UCSF. And notably, the time to infection is also variable, but usually somewhere around the 2 to 6 week mark is kind of their average. 2 to 4 week mark. Staph epi is also a very common one, and then they mentioned Enterococcus strains. Those might be introduced through L5S1 work, kind of being closer to the paraanal area. In terms of classification systems, they've attempted to distinguish different infections based on the type of the organism as well as the quality of the patient host. By anatomic type, there's 3 groups, including single organism, multi-organism, and multi-organism with myonecrosis, classifying these patients by their host quality, abnormal, and then local or systemic disease, which includes smoking, and then immunocompromised status. Based off of these classifications, they try to help guide treatments by saying that group 1 likely will resolve with single irrigation debridement, and the other 2 groups may need multiple interventions, repeat irrigation, versus a 3rd group, which is the immunocompromised group, sometimes may have to have persistent infection and be chronically suppressed, which typically portends a poor outcome. Here is a video from my residency. One less commonly described risk factor for infection is IV drug use. That's well described throughout other orthopedic procedures. These can accumulate and collect over a longer period of time before they present. Okay. So this is the most important part of the talk, is kind of figuring out how do we prevent these surgical site infections. I think the prevention strategies have evolved over time as we learn more. It's definitely still not a solved problem. I think regionally and hospital to hospital, provider to provider, practice varies greatly and sometimes feels more so based on superstition than anything else. But probably the great hope is in improving the modifiable risk factors with smoking and glycemic control. Um, there's a lot of literature describing these are predisposed to higher rates of infection, but not as many studies demonstrating that as you reduce the amount smoked or um, improve the glycemic control prior to surgery, if that affects the surgical site infection. There's some studies saying that even you have to stop for several months before you see an improvement in outcomes. In smoking, there's some data that suggests if you quit less than 4 weeks before surgery, it doesn't really change anything. Obesity is also a major problem in other parts of the country, mainly because it increases the amount of soft tissue dissection, increases your surgical time, and ultimately increases this risk of infection. Um, the incremental increase in BMI also translates to increasing risk of infection. Another area of interest is preoperatively evaluating Staph aureus colonization, which is also, being a host, has demonstrated higher rates of MRSA there, roughly, from 0.14% to 1% higher risk. In terms of skin prep, both betadine-based preps and chlorhexidine-based preps have been studied and found to be equally effective. Some studies from a while back in wearing double gloves. I think that's become standard practice, but can help you identify perforations earlier. And also some suggestions in longer cases to change gloves periodically throughout the case, as well as right before the critical parts of handling instrumentation. This was a study showing a modest but significant reduction for patients undergoing decompression surgery when showering with chlorhexidine preoperatively to try to remove the skin flora. This study compared ChloraPrep or betadine and saw a similar rate of infection, pretty low at 1%, just about. So either is acceptable. I think intraoperative wound irrigation seems to be an area where there's still some variability. There's pretty extensive literature now on betadine irrigation, which I think was adopted in total joints first. But there's several studies reporting improvement in infection rate, although basic science studies demonstrated that cytotoxicity of healthy tissue may occur at concentrations greater than 5%. Other things that have been studied: antibiotic-coated suture, triclosan-coated Vicryl has shown some reduction in infection. And one point that they found in this study was that even if you save one infection every 200, 300 cases, that's a huge cost savings. So the risk benefit in terms of avoiding infection does heavily, appeal to finding small changes that can improve on those rates. This is a systematic review from 2022, looking at povidone iodine irrigation solution compared to other irrigation types. 2,900 patients who underwent the irrigation, showing combined rate of 1.8%. infection compared to 4.6% in the control group. So they attributed this absolute risk reduction of 2.8% to the povidone wash, a risk ratio of 0.3. They noted in this figure that a subset just looking at RCTs and prospective cohorts found an even stronger signal with a risk ratio of 0.17. So probably the most convincing data out there on risk reduction is this povidone irrigation. They tried to look for other agents too, including the chlorhexidine solutions, but they only found one study thus far in 2022 that did not provide enough evidence to draw any conclusions. The chlorhexidine wash that we use does have a lot of data on it, starting in abdominal surgery that eventually went to urology and OB-GYN, and now more recently into total joints literature. It does appear to improve the infection rate. On their website, they don't mention anything about its use in spine surgery. Dr. Mundis mentioned there was a recent NIH study, but I couldn't find it. But essentially, for these common staph species that we're used to seeing, somewhere between 1 and 5 minutes exposure with our 99.95% diluted chlorhexidine wash should eradicate somewhere in the 90% of most of the bacteria. So we'll look out for the application of that in spine surgery in terms of the research. Hydrogen peroxide is another solution that's been studied. This one demonstrated a reduced drain output postoperatively and a reduction of infection rate from 2.4 to 1.4%. And then I guess this is more recent also, but kind of solved now, which is the use of intraoperative Vanc, which appears to have a protective effect without major side effects. Interestingly, this literature has been attempted to be applied to other areas of elective orthopedics with less promising, less impressive results. So in the total joints literature, Vanc powder didn't seem to affect infection rates. I try to tabulate this just to see roughly, compare most of these studies implemented using Vanc powder and then compared the results to historically. And so overall, you see the blue averages out to about 1.4%. But the pre-op infection rates were quite high in some of these groups. And again, it's quite variable group to group. So hard to know if there's anything else in their practice that may be predisposing them to infection, because I definitely don't think we see this rate of infection here. There are only a handful of reported complications that were thought to be attributable to the Vanco. 1 case of renal failure, 2 cases of hearing loss, which are known side effects of intravenous Vanco administration, anaphylaxis, which is always possible but rare, and then finally a post-op serum Vanco level measuring over 10. But by and large, with thousands of patients, there's very few side effects. Silver impregnated dressings also has been recently gaining traction. A series of 234 patients studied. This did confer some protection to infection with the reduction in SSIs, no infections seen in the silver impregnated group. And then in terms of wound vacs, it's also gaining popularity, mostly from the trauma literature. Idea is to provide a sealed environment for wound healing, and it's been demonstrated in animal studies to improve vascularity at the incision site and reduce the time to healing. Compressive seal is also thought to reduce stroma formation. Started off in lower extremity refractory surgery and at roughly half the infection rate. These are typically kind of open wounds that are uh, washed out and then closed. Anecdotally, there seems to be a lot of enthusiasm for these wound backs and modernization of the design to be uh, more easily administered and carried around. I think most people like the idea of it and would use it in cases where there's concern for difficulty healing. Um, Post-operative antibiotics, which seemingly is kind of a mainstay of elective surgery. Surprisingly, in this systemic review, there's no demonstrated benefit of post-operative antibiotics. This was looking at all spine surgery, both fusion, non-fusion. Um, they also mentioned that drain use did not seem to increase or decrease infection either. So I think, in our practice with some same day decompression surgeries going home, we don't routinely use post-op antibiotics, but I think you'll have a hard time convincing instrumented procedures that no antibiotics at all is better. Um, and then treatment. So obviously the treatment of infection can be very difficult. It's hard to know when to pull the trigger. Varying interventions from oral to IV antibiotics, debridement to the most radical cases, removing instrumentation, which is not ideal because you can cause instability in the spine if you've just recently um, done some releases. Um, and instability can also lead to further complications. This study showed 22% of patients treated with IND antibiotics and retention of implants had further infection. So kind of 1 in 5 roughly. Their failure was defined as resolution longer, persistent infection longer than 90 days or death. And their risk factors that they looked at for treatment failure included late infection, fixation down to the ileum, P. acnes or polymicrobial organisms, so greater than 5 levels operated, use of instrumentation, and protective factors included superficial infection, methicillin sensitive infection, fewer than 3 levels operated, and then based on the multivariate analysis, late infection greater than 30 days was the highest risk factor for predicting long-term persistent infection. Lastly, in terms of other options, this was an interesting approach to managing infection using closed suction and irrigation with an outflow catheter, which showed effectiveness in 75% of the cases with basically 3 and 4 succeeding after only 1 washout. The rest of the 7 had to have repeat irrigation. They were able to retain implants in all cases here, and their risk factors identified included for failure included higher blood loss, an index procedure, more levels fused, then longer hospital stays. I think this is interesting because there's sort of predicated the recent onset of endoscopic work, which naturally irrigates the wound. So perhaps there's a role for endoscopic washouts in the future to try to help preserve the soft tissue sleeve. And then lastly, in terms of trying to summarize everything and build a type of calculator to score your risk of infection, this study tries to guide, who you would expect to need multiple debridements. They looked at 128 patients and observed more than 30 variables. Did a logistic regression with a bootstrap analysis, trying to rank the predictors. And then they used a validation group of 34 patients to try and look. And so this is what they came up with: higher risk of infection with lumbar sacral location, diabetes, polymicrobial, bacteremia with pneumonia and UTI, and use of instrumentation. So kind of all previously described, but packaged up. And they gave a high risk and low risk scores that would likely be single or multiple, and then an indeterminate. And finally, just doing a global review. This is some treatment diagnosis algorithm. They emphasize looking at the histopath of the infected tissue to help also guide their antibiotic therapy. Infectious disease a lot of times wants to know how grossly infected clinically it looked. In terms of when surgery is indicated, bacteremia or sepsis, neurological deficits, progressive deformity, instability, epidural abscess, and failure of IV antibiotics to improve the infection are all warrants surgical intervention. And they again identify the same risk factors that we've seen before in other studies, guiding the antibiotic therapy with surgical biopsy is another point they emphasize. And then ultimately, if there's no improvement, you just got to rinse and repeat and keep resecting, debriding infected tissue, and repeat washout as well. Other things mentioned I didn't talk about here, but use of other local antibiotic agents getting popularity with antibiotic impregnated beads, as well as continuous irrigation systems. But those are sort of newer ideas, possibly having utility in more severe persistent infections. Thanks for tuning in.
Nice work, David. That's a lot to get through.
Yeah.
From an application perspective, what were your biggest take-homes? What are you going to do in your practice? Since, as you've seen, there's a lot of variability in the data. But
I think
you're going to apply this most succinctly.
I think from residency, seeing some practices or others, the sort of pre-op kind of indications type stuff we just did with TDSC. I feel like that's kind of the most important part, is just sitting down, looking over if there's anything that we can reduce the risk on. I feel like certain practices that indiscriminately sign people up without consideration definitely had higher infection rates and complications. Not to say that older age patients shouldn't get surgery or obese patients shouldn't be allowed to have surgery, but trying to reduce those risks, I think is meaningful. The other things variable with drain and irrigation solution. Feel like since there's so much variation in infection rate, site to site, provider to provider, paper to paper, I think everyone probably has their own micro environment of different bugs and different, like the sterility of the water we wash our hands with, things that are changing locally that kind of give you a baseline sort of infection risk that you have to manage. So I think looking in your own practice and identifying ways to reduce the risk, it has to be specific to what you're doing. But there's certain things like Vink powder that seem to overall do make a difference across the board. With Wound drainage, I think, is another thing that is difficult to understand. Some people just drain a little bit and it's okay, and other times the drainage is an obvious sign of early infection. When to do something about that, I think, is still tough. Ideally, if there's a less invasive approach like the closed irrigation that you can pull the trigger on earlier, that doesn't reset the timer for wound healing. I think that would be a nice tool if it was effective. But yeah, I think there's still definitely room for improvement. But obviously, I think infection rates have improved over the years.
One of the things that you really influences the outcome is to have a high degree of suspicion. And, sometimes you may overtreat, but at the end, you'll be successful if you just don't ignore it even for a few hours. Just, if you are suspicious, just get to it. So that's very important.
Right. Did you come across anything in the realm of taking intraoperative cultures with pseudos?
I didn't look specifically in the pseudo literature for this one, but I think infection is often like an underappreciated source of etiology of the pseudo. And the other question is the number of indolent chronic infections that aren't clinically relevant. So we know from just culturing disc tissue that a lot of people live with sort of kind of this colonization of a low load. So that threshold is harder to tell. I know there's a lot of work now in next gen sequencing in the joints literature to try to figure out if there's sort of a flora more so that isn't even showing up on the cultures that may predispose risk to worsening infection. And that may guide treatment as well. But certainly more data is always helpful from the infectious disease standpoint.
It's a little bit of a frustrating arena because there are indolent organisms that we sometimes get. We're not sure if they're contaminants like the probes, and you feel obligated to treat, but there's some guidance that suggests maybe we shouldn't be. So, as an example, we took cultures on a gal who had a successful ACDF recently, just to sort of standardize taking cultures when we're taking fixation out or doing revision. She came back with positive cultures, and our ID folks said, "Well, let's put her on antibiotics for 6 or 8 weeks." And took what would have otherwise been a very routine, easy ambulatory surgery into a bit of a painstaking event for the patient. And I'm not sure she really needed all that. So there's this still some unknowns in how we handle those things. If you have a true pseudo or true failure, clear infection, I think it's different. But have some gray areas still to be vetted.
Yeah, luckily those are not common cases. Feels like.
Well,
they do come up.
I don't know. I don't know that we're as good about it as we should be. There, if you look in the literature, there's some guidance that suggests that because there's so many false positives, and we don't know what to do with the data, it's not really representative of infection. That really you shouldn't take intraoperative cultures on revision. And I don't know what the answer is really, but there is data that suggests you shouldn't because of this very issue, that it creates a clinical dilemma that's not really appropriating treatment in a responsible, evidence-based way. So just something to think about. I don't know. I've historically, when we're revising, particularly with open stuff, I'll take intraoperative swabs just to clarify whether there was something in the wound or brewing subclinically. But I don't know. If you look at that data, maybe that's the wrong thing to be doing. Anyway, great talk, David. Anybody else?
I think it's just like it's such a hard topic because there's so many different variables, right? There's how many people come in out of the room, how well of a job did the prep person do? So at Columbia, the fellows prep for the case, and we were prepping for the first month, and there was like 2 or 3 infections, and the nursing staff freaked out. And they watched us prep, and we weren't prepping correctly. And even just in my short time here, I've seen a couple nurses prepping incorrectly according to what I was taught, and so there's so many little pitfalls here and there, and I don't know if we'll ever get our hands around this completely, but I think it was a good talk and kind of talking about all the different options.
Mm-hmm. All right. Well, thanks again, David. Have a great
All right.
day.
Have
See you
a
tomorrow.
great day. Have a great week.